Good afternoon, everyone. My name is Phuong Nguyen from Vietnam. Today is such an honor for me to be here to present about my work entitled The Cost of Medical Services at a Regional Hospital in Vietnam. My presentation today will include 5 parts. Let's get started with the introduction. Firstly, I will give you guys a little bit about the Vietnamese context. Vietnam is a lower middle income country with a population of 96 million people in 2019, and the average life expectancy of the Vietnamese population was recorded of 75 years old. Regarding the Vietnamese healthcare system, healthcare services are currently provided by both private and public hospitals. As of 2018, there were more than 1,409 hospitals, with more than 1,100 public hospitals and 228 private hospitals. Public hospitals in Vietnam play a key role in medical services delivery for the Vietnamese people. And in Vietnam, public hospital management is decentralized, corresponding with 3 levels of national administrative structure: central, provincial, and district. Central hospitals are under the management of the Ministry of Health. The Department of Health in each province will manage the provincial hospitals and district hospitals. In terms of the Vietnamese health financing reforms, public hospitals in the country have been transitioning to financial and administrative autonomy, an initiative that is partly managed and supported by the government. Correspondingly, the revenue generated from the provision of medical services through out-of-pocket from patient or through health insurance is the major source of these hospitals' budgets. This reform also has drawn a roadmap for revising medical services fees. Currently, medical services fees in the hospital were estimated based on material costs and labor costs, and in these reforms, they will consider the medical services fees to cover full costs, include material costs, labor costs, capital costs, and also indirect costs. And this revised of medical services fees therefore can help public hospital to recover costs that were previously subsidized by the government. Therefore, it's important for public hospitals managers to understand how costs are allocated to ensure the delivery of medical services at an acceptable level of quality, affordable cost, and also ensure the hospital operation. And in respect of costing data in Vietnam, we conducted a systematic review of studies about the cost of medical services in Vietnam. And we found that just few studies have explored the actual cost of medical services provided by hospitals. Most costing studies highlighted the cost of providing services for specific disease, and this cannot be generalizable for other disease. Moreover, some studies are over a decade old, which limits its application in the current context. In summary, the rationales of my study are: firstly, public hospitals play the key role in the healthcare system. Efficiency gained through allocating and utilizing limited resources among public hospitals appropriately is necessary. Secondly, reforms regarding financial management will put certain challenges on public hospitals in terms of balancing their revenue and expenditure. Hospital managers thus need to know about the services costs they provide, cost structure of their hospitals to adapt to the reforms. And last but not least, cost study of medical services in Vietnam are old and not generalizable. The study case in my study was Thủ Đức General Regional Hospital. This hospital is located in Ho Chi Minh City. the largest city in the southern Vietnam, with the capacity of 700 beds. This is also a provincial level hospital under the management of Ho Chi Minh City Department of Health. The objectives of my study is firstly to explore the cost structure at Thủ Đức General Regional Hospital and to calculate unit cost of medical services provided at this hospital. Next is the methodology part. Regarding the study design and planning, we conducted a retrospective cost analysis study under the provider perspective. About the study site, as I mentioned earlier, we conducted at Thủ Đức General Regional Hospital. All cost was estimated on the basis of data that were compiled from January to December 2019 to capture a complete budgeting cycle and minimize seasonal effects. About the costing procedure, we follow the step-by-step of the standard costing method. Firstly, we will define the cost center. According to the function of each of the 32 departments at the hospital, they were classified into either transient cost center or absorbing cost center. The transient cost center included supporting cost center, which provides support for patient care. For example, transient cost center are general planning, human resources department, financial and accounting department. In terms of absorbing cost center, the absorbing cost center were defined as direct patient service centers, which cover ancillary outpatient and inpatient services. In summary, 9 transient cost center and 23 absorbing cost center was classified for the cost analysis in 2019. The next step is determining the direct cost. The direct cost consisted of capital cost, labor cost, and material cost. Capital cost comprised the cost of capital asset and building depreciation. Labor costs cover the salary of each personnel and other general expenses, including transport allowance, recruitment costs, uniform costs, and training costs. Material costs were defined as the total expenses on drugs, medical material and consumables, utilities, outsourcing, hiring, office materials, and other miscellaneous items. For the indirect cost determination, direct costs from the transient cost center were transferred to the absorbing cost center through a simultaneous equation method with appropriate allocation basis. And to obtain the full cost incurred by each absorbing cost center, the direct cost of each absorbing cost center and the indirect cost of relevant transient cost center were summed up. And to compute the unit cost of medical services, the average cost method was employed. The unit cost of outputs were calculated by dividing the total cost of a cost center by the quantity of its outputs. For the currency, all the costs were collected in local currency Vietnam dong and inflated to 2019 prices, and result was presented in both Vietnam dong and international dollars. For the results part, firstly about the cost structure, this table shows the composition of the direct cost of all the cost centers at the case hospital. The total direct cost of this hospital in 2019 amounted to more than 38 million international dollars, and of which material costs accounted for the largest proportion of the direct costs incurred by all the cost centers. In details, the largest component of the direct costs were the cost of drugs, and followed by the salaries. This picture presented the proportion of material, labor, and capital costs in each cost center. And within individual cost center, labor costs were the main contributor to the expenses incurred by the most transient cost center, except for the Information and Technology Department A7. And in the ancillary cost center, material cost represented the largest proportion of expenses. In outpatient cost center, labor costs were the highest, similar to the case of all inpatient cost center, except for the nephrology D5 and ophthalmology D16. In terms of unit cost result, this table presented the unit cost of medical services calculated using the average cost method. With regard to ancillary services, the unit cost per prescription dispensed by the pharmacy department was around 25.66 international dollar, whereas those for laboratory tests and radiology services were 3.55 and 12.15 international dollar respectively. Surgery performed in anesthesiology department cost around more than 350 international dollar. Regarding the outpatient visits, and in the inpatient cost centers, the overall cost per case and per patient day were 323 international dollar and 46 international dollar respectively. And next, I will compare my results to other studies results and discuss about it. The findings were compared with those of FLEXA studies. FLEXA studies also conducted a cost analysis in 5 Vietnamese hospitals, including 2 district hospitals, 2 provincial hospitals, and 1 central hospital. FLEXA collected data in 2000 and similarly used the standard costing method to determine the cost structures and unit costs incurred by these hospitals. When comparing, we found that the cost structure in our case hospital is inconsistent with those of the hospital of the same level as ours, which means 2 provincial hospitals and the higher level hospital in terms of the ratio of material cost to labor cost and capital cost. These ratios indicate that material costs were the largest proportion compared with the 2 other cost components in these hospitals. These results so can help hospital directors pay attention to material costs if they wish to decrease some expenses in their hospital. However, the cost structure in the present study was not of the same direction as those of the lower level hospital in FLEXA study, where labor costs were the most important expenses in these 2 district hospitals. This difference suggests that cost importance depends on the level of healthcare provided by Vietnamese hospitals. FLEXA also calculated the unit cost of medical services by dividing the total cost of each cost center by an appropriate measures of its output. And the comparison of unit cost from our study to FLEXA study concluded that variation of unit cost of medical services depends on the hospital level, and unit cost per radiology service and laboratory tests are quite diverse and different among hospitals. Finally, the unit cost of medical services in the present research differ from those determined in studies conducted in India, Cambodia, and Myanmar. This difference implies that study location and pattern of resource utilization lead to differences in healthcare service costs. Our study has some strengths. Firstly, the study used the standard costing method that is recommended for cost analysis, as well as used in other studies in many countries, including Vietnam, India, Thailand, Bangladesh. Therefore, the reliability of the results could be assured. Secondly, there has been a paucity of research on hospital cost analysis in Vietnam, and not to mention that these analysis was old-fashioned. So the unit cost of medical services of this study can thus be served as a reference for other hospitals in Vietnam. And however, our study also has some limitations. Firstly, the output of the nephrology cut center was reported as cost per inpatient case, but the services provided by this cut center were completed within a few hours. Therefore, these results should be used with the caution of this issue. Secondly, some capital items supposedly cost nothing because they exceeded their useful life, and their inclusion might have caused an underestimation of capital costs. And another constraint is that our study conducted just at a single facility, so with limited comparison with hospitals that are of the same level in determining whether the costing management in the case hospital was of good quality. And in conclusion, we have successfully explored the cost structure at the hospital and as well as calculated the unit cost of medical services at this hospital. From this study, we also give some recommendation for the hospital's managers and the policymakers. For the hospital managers, more attention should be focused on the material cost if the hospital wishes to reduce the cost incurred in the hospital, because material cost accounted for the likely proportion of the hospital. Secondly, given incomplete data in some cases, which could have affected the completeness of the analysis, the hospital managers will find a way to improve the data management, the data recording system, so that future study could provide a better analysis. And for policymakers, this analysis can also be beneficial for them in terms of developing the standard costing guideline for hospitals to adapt and use in the future. And in addition, a training course about how to conduct costing analysis using available costing template developed from this study could be taken into consideration in hospitals. And that's all for my presentation. Thank you for your attention. And I welcome all of your comments and questions.
Okay, now we open for the question from the audience. Okay, so I may have question for you. So you mentioned about the study. I just want to know the cost effective that you study is from private sector or the public hospital?
Thank you for your questions. This hospital is a public hospital in Vietnam.
Public hospital.
Yes.
And you compare the cost on your slide 77. Can you move to 27?
This slide.
Yeah, so this information that you compare the cost of the other country, unfortunately, there is no Thailand. Why you don't have information about Thailand? It's maybe more interesting.
It's might because like I don't find like the hospital like have the same level to the hospitals in my countries. Or maybe I will research and
So from this slide, the Cambodia seem to be the highest cost for medical service. And here, Vietnam seem to be the lowest. Myanmar is very high there. But what do you think about Thailand? Lower or higher?
I cannot guess the result because I think the healthcare system in Vietnam and Thailand like are totally different. And also the health insurance scheme in Vietnam and Thailand also different.
See, okay. All right. So, and on your slide 25, can you move to 25?
This line, Ajahn.
Yeah, this one. So in this slide, the cost also depend on the region of the hospital, right?
Yes,
The
Ajahn.
district seem to be lower. The province seem to be higher. But all of this hospital is public, right? Public hospital.
Yes, all hospitals are public hospitals.
Mhm. Quite interesting to know. So the aim of this study, when you know about the cost, what is the aim of this study then?
Could you say the question again?
What is the objective if you know the cost of the medical service?
This can help the hospital managers like
Mm.
know about the cost structure of the hospital, like which one accounted for the most. And so in the future, when they have to manage the cost by themselves, like in the future, the government will not subsidize for the hospitals, and the revenue in the hospitals have to recovery by themselves through the through the provision of medical services. So
Yeah.
like
Yeah.
it's
And
a
from here we can see the material cost seem to be the highest. Right?
yes,
But
Ajahn.
the material cost, can we reduce the material cost? For the other costs seem to be we cannot reduce, right? Labor cost, capital cost, that seem to be fixed.
Yes, Ajahn. If the hospital manager would like to change, like they should pay attention more to the material cost.
Yeah. Okay. So thank you very much to Nguyen. So